Good morning, good afternoon, and good evening, everyone. Thank you for joining us from across the globe. On behalf of the UNFPA-UNICEF Joint Program on the Elimination of FGM, the Medical Women's International Association, the Office of the United Nations High Commissioner for Human Rights, and the World Health Organization, we welcome you all to today's webinar event entitled Female Genital Mutilation and its Medicalization, Health Complications, Rights, Policy, Strategies, and Pushback. Before we dive in, I have a few quick notes. To accommodate our diverse audience, there is French interpretation services available. Please click on the interpretation button. We kindly request the speakers to speak at a pace to enable interpreters to follow. Please use the live chat to tell us who you are and where you're joining us from. And also, feel free to submit your questions throughout the webinar using the Q&A tab. My name is Dr. Wisal Ahmed. I am the Global Coordinator of the UNFPA-UNICEF Joint Program on the Elimination of Female Genital Mutilation and the advisor in the Technical Division of the UNFPA headquarters. It's my pleasure to be your moderator today. So let's get started. What is female genital mutilation? Female genital mutilation comprises of all procedures that involve the partial or total removal of external genitalia or other injury to the female genital organs for non-medical reasons. Over 230 million girls and women alive today have undergone some form of female genital mutilation. 68 million girls are at risk of undergoing this practice between 2015 to 2030. And a whopping $1.4 billion are spent every year to treat its health complications. So what is FGM medicalization? FGM medicalization refers to situations in which FGM is practiced by any category of healthcare providers, whether they are in the public or private clinic, at home or elsewhere. It also includes the procedure of re-infibulation, which is the closure of what we call FGM type 3, or what is known as pharaonic, at any point in time in a woman's life. 66% of girls have FGM performed by health workers. And countries where FGM medicalization is present also have high FGM prevalence. What are the drivers of FGM? It is driven by customs and beliefs that are considered to be necessary, either to the passage as a passage to womanhood, for marriage, and to control sexuality, to promote marital virginity and maintain marital fidelity. There is also this belief that this practice is a religious rite. Health workers are involved in FGM because there is this perceived risk that it is safer. It is thought that if they involve health workers, this will end FGM. And health workers who practice it believe in the customs around FGM, and some are paid to perform this practice. So with the backdrop of the growing calls for FGM medicalization as an alternative or safer option to continue FGM practice, this webinar aims to provide frontline health workers, professional associations, ministries of health, and civil society activists the necessary information, resources to strengthen their interventions towards elimination of all forms of FGM, including its medicalization. We have a lineup of distinguished speakers and experts from the Ministries of Health, International Health Professional Association, health professional experts working in settings where FGM and its medicalization, where in settings where it's prevalent and the practice is interlinked with religion. And we also have representatives from diverse United Nations. So I would like to welcome everyone and honored to start this webinar with a video message from our distinguished human rights advocate, Dr. Klalang Mofokeng, the UN Special Rapporteur on the Right to Health. I welcome you to listen to her opening remarks.
My name is Dr. Klalang Mofokeng. I'm the UN Special Rapporteur on the right of everyone to the highest attainable standard of physical and mental health. Female genital mutilation constitutes a severe violation of human rights. As acknowledged by many international standards and resolutions, including the right to health, it inflicts irreparable harm on women and girls, impairing their rights to health, physical and bodily integrity, freedom from violence and discrimination, as well as stigmatization. Female genital mutilation, commonly known as FGM, can never be a so-called safe procedure, and there is no medical justification for this practice. FGM poses major health risks, but also affects women's and girls' ability to participate in the economy. It affects their civil rights, their political rights, as well as their cultural rights. This is a procedure that I do not support and wholly reject, where healthcare providers perform this procedure of FGM. It is still dangerous and still unethical and still violates human rights. Despite the clinical setting where it's being conducted, it does not make the human rights violation any less important, visible, expressed, or felt by women and girls. FGMs remain inherently harmful and violates medical ethics. It also is important to understand that medicalization may inadvertently legitimize this practice, perpetuating the cycle of violence against women in health facilities, in societies, but also in a way in which medicine itself views women and girls. Female genital mutilation is not a cultural or religious requirement or a fundamental showing of one's commitment to culture or religion. It is a form of physical, mental, emotional violence against women and girls. By medicalizing FGM, we are creating a systemic, structural layer of violence where we will enable doctors and healthcare providers to perpetuate violence against women and girls. It is imperative to prioritize the health, sexual and reproductive health rights, and the well-being of every individual by ending the practice of female genital mutilation. The role, the obligation, and the responsibility of prevention is ever more important and urgent as we speak today about female genital mutilation and the regression in laws, but also the move to try and medicalize FGM. Governments, policymakers, healthcare providers, and legal authorities and practitioners have a collective responsibility to end and combat FGM. Moving forward, all efforts must focus on mobilizing political will, strengthening healthcare provider knowledge, especially on human rights and the right to health, and how their practice of medicine can protect and promote human rights. We must create supportive legal environments and frameworks and ensuring that there is monitoring, transparency that will eventually lead to accountability. We know in many jurisdictions, in many governments around the world, this issue is heavily stigmatized, and it's very hard for people who are either at a threat of experiencing FGM, or those who have experienced FGM, or society and family members and caregivers of those who have experienced FGM, to actually speak up as much and to actually then get some kind of accountability. It is my call to remind member states of the United Nations that they have an obligation under the right to health to promote, to protect, and to realize the right to health. In this context of FGM, we must hold those people who continue to practice and perpetrate this practice accountable for their actions. There must be redress, there must be accountability, and there must be transparency and a move towards a reparative justice process where we can listen to women and girls and hear what it is that they want and what justice looks like for them.
Thank you, Dr. Mopokeng, for your insightful message. Powerfully frames FGM and its medicalized form, which is a fundamental violation of human rights, and its medicalization systemizes and perpetuates this practice. I would like to move on so that we can delve deeper to understand the health consequences of FGM. We are honored to welcome Dr. Taiwo Oyelat, medical officer, a medical officer in the Gender Equity Human Rights in the World Health Organization Regional Office for Africa. Dr. Taiwo, thank you for joining us. The floor is yours.
So, good morning, good afternoon, good evening, everyone. It is my pleasure to present the health complications of female genital mutilation on behalf of the World Health Organization. Can we have the next slide? Yeah. Before we go on to the health complications, just to reiterate again that female genital mutilation is a harmful practice, and there are evidences that FGM is associated with multiple health complications. There are no health benefits to FGM. Already 230 million women and girls are affected, and health workers performing FGM violates the principle of do no harm, and further perpetuate and legitimizes this harmful practice. WHO and UN partners were working closely to stop the medicalization of FGM and provide high quality care to women and girls who are already affected. Next slide, please. So WHO conducted a series of studies to come up with the evidence-based on the health complications of female genital mutilation. Papers published from 2009 to 2022 went through systematic review and meta-analysis of the related studies to identify the health complications of FGM among women who had FGM with women without FGM as a comparison. Inclusion criteria include papers with comparison groups, no limitations on age, race, ethnicity, nationality, and the settings. Papers with no comparison group, case studies, qualitative studies were exempted. So separate analysis was also conducted on immediate health complications using 11 studies with data on proportion of girls who had immediate health complications following FGM. So the studies were from more than 30 countries, as you're seeing on the screen, including 2 studies from the Gambia, Morrison et al. And Kaplan et al., which also look at the long-term reproductive health consequences and long-term health consequences and complications of FGM during delivery and for the newborn. So this about 67 studies were selected based on the inclusion criteria, and they are in the following domains: obstetric complications, neonatal complications, gynecological complications, urological complications, mental health complications, and sexual health complications. So the findings clearly showed that women with any type of FGM are more likely to have obstetric complications, and this include postpartum hemorrhage, prolonged / obstructed labor. They are more likely to deliver by cesarean section. They're more likely to have obstetric tears, and have extended hospital stay after delivery. And likewise, their newborns are more likely to have fetal distress, including neonatal asphyxia. They're more likely to be stillborn, and they have early neonatal death. Other complications include gynecological and urological consequences. The gynecological complications also exist in women with any type of FGM, and they include genital tissue damage, menstrual difficulties, reproductive tract infections, and the urological complications include urinary tract infections and difficulty urinating. So the complications are not limited to obstetric and gynecological complications. We also have mental health and sexual health consequences. So women with any type of FGM are also more likely to be depressed or have anxiety disorder. They're also more likely to have somatoform disorder, which are, clinically significant, but without any with unidentified symptoms. So we also looked at the data from demographic and health surveys and multiple indicator cluster surveys regarding immediate health complications of FGM. And you can see that for any type of FGM, immediate complications include excessive bleeding, difficulties urinating, difficulties with wound healing, infections, and swelling in the genital area. So WHO and partners have developed a package of resources to promote FGM prevention and to ensure women and girls affected receive the care that they need. So the WHO guidelines on the management of health complications from female genital mutilation look at 4 domains with recommendations and best practices statements. These domains include the infibulation domain, stressing the importance of the infibulation for women who have undergone FGM to prevent obstetric, gynecological, and urological complications. It also looks at the mental health domain to ensure that women experiencing mental health complications receive quality mental health care and services. Again, it looks at the female sexual health domain to ensure that there's appropriate counseling to address sexual health complications of FGM. And lastly, it looks at the information and education domain in the context of provision of care and decision-making about treatment. The guidelines were also the basis for development of this clinical handbook, which was launched in 2018 and includes chapters on each of the categories of the health complications, immediate gynecological, urological, obstetric, mental health, and sexual health complications, and providing guidance on how health workers can manage these conditions. Also, there is a chapter on the importance of sensitive and person-centered communications with women seeking care in order to promote prevention and to ensure that care is provided sensitively. WHO and UN partners, including UNICEF, UNFPA, UN Women, UNDP, UNAIDS, and professional associations, including FIGO, ICN, ICM, launched a global strategy to end medicalization of FGM based on the complications as we have highlighted, and the strategy to stop medicalization is organized around 4 pillars of action. The first one is to mobilize political will and funding. Second one is to strengthen the understanding and the knowledge of healthcare providers, which we seem to contribute to with this webinar. Third one is to create supportive legislative and regulatory frameworks. And lastly, the fourth pillar is to strengthen monitoring, evaluation, and accountability. WHO and UN partners are implementing this global strategy currently with a focus on countries with high prevalence of FGM. We have also heard that FGM is not without cost to the countries where it's currently being practiced. So WHO has developed this FGM cost calculator, which is an interactive online tool to visualize country by country the current healthcare cost of FGM and the projected cost savings if FGM is presented. So what you have seen on the screen is the screenshot for the Gambia. And if we continue with business as usual, 1.3 million girls are projected to undergo FGM by 2047. And the costs are projected to rise to $8.4 million per year by 2047. On the other hand, if the Gambia is able to achieve full abandonment by 2047, about 870,000 girls will be protected and from undergoing FGM, and the country will save at least $5.7 million per year. So this tool is available for all countries, and each of the countries can use the calculator to look at, to interact and see the cost savings that they will be accruing to them if they're able to reach full abandonment. So the key messages from this presentation is that FGM surely has multiple health complications, and with FGM, the risk of these complications increases significantly. Preventing female genital mutilation will reduce this health risk and health care costs because there are no benefits to FGM. It only brings harm. In this regard, health workers should never be involved in the performance of FGM. In fact, they should advocate for prevention of female genital mutilation in their communities. The global community also has to step up mobilization to end this harmful practice, and this should be done through multi-sectoral and multi-pronged approaches, as highlighted in the global strategy. So we must sustain our actions in order to end FGM, to ensure that women and girls already affected also receive quality care and the support that they need. So thank you very much. This is the presentation from WHO. You can scan this QR code to get more information on WHO's effort to prevent and respond to FGM. Many thanks to our colleague, Christina Palito, for the efforts put into getting this together, and all other colleagues in WHO HQ and WHO Regional Office for Africa. Thank you very much. Over.
Thank you, Dr. Taiwo, for the detailed presentation of the many health consequences related to female genital mutilation that is supported by strong evidence, and also for sharing the available resources that could guide health workers in their work and for advocacy for policymakers. Dear participants, I would like to just invite you to feel free to submit your questions in the Q&A function. Only the wearer knows where the shoe pinches. I'd like to invite you all to listen to a survivor's real experience. We are privileged to hear from Ms. Aida Balde, who will courageously share her personal story about living with FGM. Ms. Aida, welcome.
Yeah, and thank you all for inviting me here. I'm very glad to be part of this meeting today. It's a privilege for me. And once again, I am Aida Balde. I'm working on the network against gender-based violence, and I am a survivor. And I'll be pleased to talk about my story, or just give a brief about my story because the time is not there. I am a survivor on the FGM. The last 15 years ago, because today I am 25 of age. So I have a lot to say, but to be honest, the time is not there. So let's just hear the painful part of it about my life or about the experience that I have been living with under this FGM. I have gone under FGM and I have been caught, not only been caught, but I am also sealed. And till date, this is in me. So the impact that it has brought into my life is that I have been a girl that cannot express herself to her mates, in a sense that it has affected me in all ways. Like in my health issue, it has come in a way that it gives me every month, let's say, I experience a very bad pain when it comes to my menstrual cycle. So this thing drains me a lot. It drains me all the time. Any month that I am to experience or to see my mens, it's like I don't wish it could happen. That's just the single part of it, let's say, because in me, I have no space whereby air can enter in me like the way I want. The space that I have in me is very, 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 very small. So it has been the reason why, in fact, to my age here, all my mates are married. And I'm from a flock community whereby a girl like me cannot reach to 25 years of age without being given to a husband. So to me, thank God, I am educated and I know the importance of education, and my family knows the importance of education. They have led me to go to school and to reach where I am today. But with all that, the society where I am living, they point fingers on me. Why are you not still married? But in me, I feel like I don't want to get married. The reason being is that I know what I have to go through when I am to get married. So it's like I have a dislike of men's, in fact. Anytime I think about I have to be on seal to make love to the husband of me, or to let's say to make love to the man that I am supposed to marry. But knowing that I have to be on seal is a problem. That's a mental trauma that I am going through. And that's really disturbed me a lot. Even if I want to make a decision like, yes, let me give a chance to man, I cannot, because it's like if I see them, it's like they are the one who is going to hurt me. And then that's not the case. But because I know the pain that I am going to gain in the future, in the nearest future, because I have been asking doctors, I have been asking married women, because to me it's a concern, like how do they face this thing? Somebody that is been sealed, you are not only been caught, but you are sealed in a way that you cannot even give yourself to a man unless and until you have to go back to those people, those traditional people, to unseal you again for you to have your man with you. So when I asked for it, there was let's say in few months back, I was having a case management training with Joy and others. There was a doctor. I have to call him aside and explain my story to him. And he feels so sorry for me. And he was like, I will advise you not to go back to that tradition again. But instead, if you want to remove this in you, because really it is disturbing. If even somebody sees you, will know that yes, in order for you to gain your body back, you need space, you need air in you. But either you are just too tight, because by that time, I already made a decision that I want to remove it. He said I cannot remove it. The only way I can remove it is after removing it, I must have sex. And in my culture, it's like you cannot lose your virginity without being married, because I am a fuller, and that's what we believe in. If they are to give you out to your husband, they have to meet you as a virgin. So the doctor asked me not to remove it. If I have to remove it, it's until and unless if I am going to my husband the next day. If not, if I have to remove it, it means I will not be a virgin anymore. So when he said that to me, I was like, okay, fine. But I will also assure you that even if I am to unseal, I will not go back to those Ngansimbas again to use their eraser blade to tear me, because I can still remember when this process was going on. It's like I am even seeing it. This is why it is a very big problem for me to even hold a eraser in my hand. It's very difficult. Oh, let me see blood. It's like I am seeing myself in the process again. So it traumatized me all the time. And still now, here I am. If I want to get married, because I have people who are approaching me, but the reason being only me who knows. And my mom knows, yes, I am sealed, but the rest don't know. Sometimes they'll be like, why are you insisting? Why are you insisting? Now I am even being open up, because where I am working, they deal with these issues, gender-based violence. So I said, okay, fine. I am a survivor. Let me not keep quiet. Let me be bold enough to share my story and to tell people that this is me. If somebody have to love me, let the person love me like this. If somebody have to hate me, let the person hate me like that. But I think I have a voice, or I can save someone's life, because I have tell them that I have made up my mind, because I am thinking a day that I am going to go through that process again. In fact, maybe then I was just too little that I could not imagine the too much of pain in the future. But now that I know, and it's like I'm not even prepared for it. I'm not ready for it. So it's a whole lot. And if I have to explain here, I will explain till tomorrow. I cannot even have a half of it. Like the way I used to feel. Anytime I'm explaining, I feel like crying, honestly. I feel like the pain is just too much and I cannot contain the pain, knowing that what I have to face. Yes, please.
Thank you, Ms. Balde, for your courage to share your experience and your testimony that highlighted the health effects of FGM and on your social life. Thank you for sharing your experience and reminding us about the need to end this harmful practice. Thank you once again. I'd like to move on to the efforts that are being done right now by the Ministry of Health in the Gambia. I'd like to welcome Dr. Mustafa Bitay, Director of the Health Services at the Gambia Ministry of Health. Welcome, Dr. Mustafa.
Thank you very much. And thank you, Madam Balde, for sharing your testimony. So you'll put up this slide for me, please. Yes, like she said, I am Mustafa Bite. I'm the Director of Health Services at the Ministry of Health. So the outline we have is to just briefly give you what is defined as medicalization, the status of the Gambia at present, and the prevention strategies that the ministry is contributing towards supporting the Ministry of Gender in implementing, and conclusion. So we've already discussed, we've been given the signs, and what the medicalization means is that, when health providers are involved, doesn't matter the cadre, and it doesn't matter the place. Maybe it could be in a hospital, in a house, in a private clinic, it doesn't matter. That's medicalization. And the data we are seeing is that it's moving towards, it's becoming a trend. As if you go to some countries, you see there's the younger population that is doing this medicalization. So it means that the older population have not done it. So it's something that is creeping in, and it's mainly happening among the younger ones. So it's becoming a trend. So there are a lot of reasons why people do it. And the first one that most health professionals say is that they want to do harm reduction. There are two harms. There could be something from infection and other things that they are saying. And they say that, okay, there is 100% danger, so let me reduce it to 75%. And others are saying that it's cultural practice of the people, and these young people who've not reached the age of consent, need to undergo this procedure because, cultural practice, they say. Some say because of financial gains, because in some other places it's very lucrative, because most health providers will not perform it, and so the little or small group that is doing it, they get a lot of resources from it, and it's very difficult to get them to stop. Some feel they are pressured either by their communities, their families, and others, so they give in to the pressure, and then succumb and then start doing it. Now, I think the most famous one is in Egypt, where they allowed it from the government as a degree in '94, and then, thought that they were also thinking of harm reduction, but they realized later that actually it was still very harmful, and then they had to stop it, ban it. But then it's already into the hands of these people who are getting financial gain, so it's become very difficult to get the practice out of the whole system. So many people might not know the country. Gambia is a very small country. I think it's the smallest in mainland Africa. And now we are a little more than 2.5 million in our population. And the prevalence ranges. Some studies will say 76.3, some will say 73, but it's around that, is above 70%. It's important to note that until recently in the Gambia, most of the doctors trained here train outside, myself included, and others. We do our undergraduate in the Gambia, but our postgraduate, usually we have to go outside the Gambia. And but now we have started a postgraduate training in Gambia, so the number of specialists coming up is increasing, and there's need to discuss this and ensure that it's ingrained and it's integrated into the system. We think that medicalization might be going on in the Gambia, but it might be at a very low scale. So in the Gambia, what is being done is that it's already recognized in this country that FGMC is a problem. It's been recognized for decades now. We have very strong women and men who've worked very hard for many years to ensure that people have been educated. There's been a lot of advocacy and sensitization for many decades now. And that means that we've already identified it as a problem. And another good thing is that I was even involved in the introduction of this FGMC, gender-based violence, into the curricula of the nursing programs. And at the time, we had also the coordinator of the medical school ensured that gender-based violence was part of the medical school curriculum. So these are things that have happened and are still ongoing in the Gambia. So in the Gambia also, the Minister of Health has been a very strong ally and had the political will for many years. One of the former vice presidents of this country is a very strong advocate against gender-based violence and was one time Minister of Health. We have Aissatou Toure, Honorable, was also Minister of Health. These are very strong people who are against gender-based violence. So the Minister of Health has historically been very strong against gender-based violence. And the current minister and the ministry is also strongly have strong leadership and political will to ensure that we end all forms of gender-based violence. Now what has happened is that the Minister of Health and Social Welfare used to be responsible for a lot of issues related to vulnerability and others. But now it has been transferred to Minister of Gender and Children. And it's more up there. The mothers and the children are taken care of there. But the contribution of the Minister of Health continues. We are still part of the steering committee, and we are a strong member of the steering committee that looks at all these. Like we regularly have meetings. We steer the whole activities of gender-based violence, stimulate regulations, sensitization, advocacy, actions, and we work as a team. And this includes ministries that are relevant, vice president's office, it includes relevant NGOs, and it also includes all the players and stakeholders and gives us a forum where we discuss regularly towards the implementation and to get everybody on board. So this is where Network Against Gender-Based Violence is there, Wasukafo, all the partners here are there who participate in this good forum, which allows us to discuss these issues and how to tackle them. As a country, we have a lot of strength, but we also have few weaknesses. Some of these are very recent. Like, for example, the reproductive health unit in the country, is inclined towards medicalization. This is a big problem as a health sector, even though the central level is very strong about it, but we need to do more work even internally to ensure that all the appendages of the Minister of Health are in sync and work towards the same aim and objective. For example, another weakness that we have is that amongst specialists in the Edward Francis Small Teaching Hospital, which is the biggest teaching hospital, maybe you have about 5 or 6 consultants. So, for example, the head is the only one that I know that is pro this. And of course, the head of department and has come out public to say it. So even though it's a minority in the whole department, it carries a lot of weight and it sends a lot of mixed signals. The other problem we have is that we have many young specialist doctors that are female doctors that have gone through the process who are really not vocal, but you could see that they don't support the FGM and they want the plan to continue and they want to continue to advocate and help people. But we have also a small group of very, very strong young male doctors who are really advocates of the female circumcision, they call it, and they are pushing. And I think this is a big weakness that we have in our settings now. But generally, the Minister of Health is very strong, and the head continues to lead the way to say that strongly against, please next slide, is still strongly against medicalization. And we continue to advocate to ensure that we don't put this type of practice into our system. where we will regret it and want to come back, and it will be difficult. And another opportunity is that we have a huge number of young specialists who are females, for example, in obstetrics and gynecology, or generally doctors, who might have gone through this, but they are not, they don't want anybody else to go through this because of the consequences they've suffered. So there are big opportunities that could be used to continue to do the advocacy and sensitization. So the prevention strategies we are doing, we are in a position to say that we really want to maintain the ban. We are talking about the laws. There's a law that is brought in 2015 December that has banned the practice of female genital mutilation or cutting, but there's a lot of new voices saying that it needs to be medicalized and all. And the Minister of Health continues to say that this is not the stance we're taking. What we want is to do more advocacy, more sensitization, but medicalization is not the way to go. And we also continue to encourage the advocacy and sensitization that is going on, and continue to support Ministry of Gender in the prevention roles. But any complications that happen through these gender-based issues, we sort it out. For example, we work with UNFPA Network Against Gender Violence and others to ensure that we have one-stop shops or one-stop centers in most of our facilities, so that complications that arise from these situations, we deal with it quickly without putting them through multiple trauma processes. And I think this is yielding dividend, and we've gradually expanded this program. So I'll close finally by saying that we all know that there is no medical benefit for doing this procedure, and the Minister of Health sees it that way and continue to say that we should stop this type of practice in this country and continue the advocacy and also continue the sensitization at all levels. We don't want what happened in Egypt to happen in Gambia, and we are all standing against that. Thank you very much.
Thank you. Thank you indeed, Dr. Mustafa Bitay, for sharing the status in the Gambia, the Ministry of Health's ongoing efforts to stop FGM and its medicalization, the challenges faced, as well as the opportunities. I'd like to move on to the next speaker, and start by saying that working in settings where FGM and its medicalization is challenging, and is even more challenging where this practice is linked to beliefs that it is a religious right. I'd like to invite Professor Ahmed Ragab, the professor and senior consultant in the reproductive health in Al-Azhar University in Egypt, vice chair of Faith to Action Network, and chairman of the Family Culture Committee of the Egyptian Family House Association. Welcome, Dr. and Professor Ahmed Ragab. I'd like to start by asking you, why did Egypt make a decision many years ago to implement FGM medicalization, and how did that experience go?
Before starting, I would like to tell you how I am pleased to speak to Gambia. I visited this beautiful country during my work at the Cairo Demographic Center. I have several students from Gambia, and to my surprise, all of them, their master thesis, their theses were about FGM in Gambia. That is, tell you, it is important. Actually, if we are talking about history, Egypt, since Pharaonic time, we practice FGM. And some claim that it came to spread through Africa from Egypt, but this is not true. In Egypt, because we know FGM predates Islam, but it is linked to Islam. I don't know why. If you look to from geographical point of view, you will see that most of the Muslim countries do not practice, even do not know what is FGM. And in Egypt, they started, in order to reduce the complication, there was a ministerial decree to perform it in hospitals. And they sent letters to the hospitals to identify one day to perform that. Then another ministerial decree to prevent other people like barbers and traditional birth attendants from performing. Then another ministerial decree to prevent having the breaths in the hospitals due to complications. There was recorded. This is in clinics with best hand medical doctors, several diseases, and this was known before there was disease, but they were shrouded in silence. They do not talk about them. But with human rights advocates, with the NGO, this started to go to the surface. Actually, in Egypt, we thought what we can do. Medical doctors claim that the religious leaders are the one who advocate for FGM, and that is the people are demanding from the doctors this procedure, and the procedure, the doctor think that it is better for me to perform it in a symbolic way, in a clean settings, in taking all the measures to prevent complications, rather than to go to traditional circumcision, which is proved to be not true because of the complications there. Complication of anesthesia, the complication of the wound itself, the psychological complications. Girls are saying that this is the black day of the circumcision. A girl told me, I hate my mother because she was the one who decided to circumcise me, something like that.
Thank you. And what has Egypt done to address FGM medicalization and to de-link it from Islam?
Dealing from Islam, we published several books on that. Actually, I conducted a study in 5 governorates, 5 counties in Egypt. I met religious leaders and I asked, this study was for UNICEF. I asked them what you would like to know about FGM. And I listed their questions and answers. And I categorized them into 31 questions. And I answered them in a book called Questions and Answers Regarding FGM. And it is published by UNICEF, and it is available on the internet. Then I realized that there was missing parts. I heard again some other parts. So we published another book in which female circumcision, female genital mutilation between the incorrect information and misinterpretation of the religion. And this, the summary of it is available in English. Then WHO, I wrote a book for WHO in which this is for the workers and eradication of FGM. And in it, there is a part in which I created a dialogue between religious leaders supporting FGM and a religious leader who is opposing FGM. It is very, very, very comprehensive. In Egypt also there was programs for medical doctors. There is a very strong program and materials to educate medical doctors about the risks, and this was done by the Ministry of Health with one NGO, and the materials are available, and they did a very strong program for 1 year to educate medical doctors. But you know, in Egypt we have economic problem, and FGM costs bring the medical doctors a lot of money. So I think the doctors who do not have moral values, who do not stick to the ethical complication, can go for it. And because people still till now think of how to control the sexuality of women. They believe that if a woman is not circumcised, she goes after men, as some sort of a worker or postman came to the house, there would be a relation. This is, we need to tell the people that women are very faithful to their husbands. This is not the case. Even some rumors that the jeans trousers, the tight jeans trousers can arouse hair. All these misconceptions, we deal with them, but we should continuously deal with them.
Thank you. This is very interesting. Because of time, I'm just going to ask you, what are the 3 key messages and learnings that you can share from Egypt's experience?
Before sharing the key messages, actually the FGM now is criminalized, and the sentence is doubled for the medical doctors or health providers, and even the parents who take the decision, they are also criminalized, and there is penalty 3 to 5 years on hard labor. The key message to not Egypt, all over the world, for the health provider, you should stick to the ethical values. You should look for the future of those girls, because complications may stay all over their life. They do not, some of them do not enjoy marital life and sexual health. And the last is religion of Islam does not mandate FGM, and they even fight FGM, and consider harming the body of human being is a sin, and it will be punished in the world and in the hereafter. Thank you.
Thank you. Thank you very much. Really enjoyed that. Thank you, Dr. Ahmed. There's one question that was submitted on how does the medicalization of female genital mutilation impact the efforts to end FGM? I'd like to ask any of the panelists to answer this question. Dr. Taiwo?
I think this point was highlighted by the first speaker. I mean, the medicalization, I mean, generally will legitimize, it will give, you know, some kind of acceptance to female genital mutilation. And it's also a weapon for those who still want to continue the practice of FGM, to say that the medical profession has sanctioned that this should continue, even if they cannot do it under the traditional environment. They can do it under clean and hygienic environment of the health facilities, which is likely to discredit all the efforts over the years, because whether female genital mutilation is performed, I mean the site where it is performed is not the issue, but the fact that it doesn't have any health benefit, and also doing it under medical environment, so medicalizing it does not remove the complications, as we have heard from the senior colleague from Egypt. So I think this is the message, and as healthcare professionals, we should not take part in this, so that we don't continue to perpetrate this evil act. Thank you.
Thank you very much. There is a comment from one of the, Dr. Ahmed, please.
The message by the health provider affects a lot of the people. I am going to do a symbolic thing to fulfill the Sharia requirements. I'll make it as a beautifying procedure. Oh, what is this ugly labia? We should trim it a little. If you see in the United States, they are doing trimming of the labia minora to be beautiful and to be able to marry and to live a happy life. This is the message given by the providers of FGM. How can you refuse?
Thank you very much. There are some questions. Again, maybe Dr. Ahmed, there are two questions from Egypt. One is asking, has Egypt prosecuted cases of FGM medicalization? And the second question, is there evidence that it was performed by the pharaohs? Over to you.
I'll answer the second question first. There is no evidence at all. I did a study on this. There is no evidence at all. It is performed by the pharaohs. Actually, the pharaohs record every single item in their life. You will find evidence for female circumcision, but you can't find any evidence of female circumcision. Even those who examined the mummies, the female mummies, they couldn't come to a conclusion that it was performed by pharaohs. What is the first question?
The second question, was there any case of the prosecution of FGM medicalization cases? Has it gone to court, and were the health professionals sentenced?
Yes, there is several cases went to the court and sentenced, and I know one governor called Sharqiya who has been sentenced. But a clever attorney, a clever can make this was a necessity, and no one complain except if there is complications happen. The cases of this, people were complained and the court took actions.
Thank you. There is a question on FGM survivor story, which moved a lot of the audience. There was a question whether there are surgical services, and this is open to all panelists. If there are surgical services to support, FGM complications available, and are they easily accessible? This is one. Yes. And are there any associations that are willing to partner to help patients or FGM survivors who cannot afford interventions? Over to the panelists. Yes, Dr. Taiwo?
Yes, the guidelines that we presented earlier, actually, there is a section on providing defibrillation for women who have undergone FGM to prevent obstetric, gynecological, and urological complications. So this is available, and WHO is promoting this to prevent these complications. But what I don't know is, maybe we have organizations that are helping to support women who have undergone FGM to have these services freely, or to provide them with other support that they will need in order to have these services. So maybe we have colleagues who have information about organizations who are working in this area who can be contacted to help. Thank you.
Yes, Dr. Ahmed.
Actually, there were attempts to have organizations or bodies, and one was in Somalia, in Busasu, to help the victims of FGM. But I don't think it survived. There is two success stories, and I hope it will be replicated in Gambia. In Egypt, in governorate called the Bani Suef, a group of NGOs, Christians and Muslims, collected stories from FGM victims. Very horrific stories. And during my study in Somalia, in which I covered the 3 zones, I collected about 30 stories from the traditional circumcisers about FGM. I can share this with you. But UNICEF is published. Mine is not published.
Thank you. Thank you very much. We are close to end of this webinar. It was unfortunate that we were not able to hear about the Nigeria experience, and we would probably share maybe through social media some of the key learnings. I would like to end this webinar by thanking all the panelists. We've heard compelling statement by the Special Rapporteur on the human rights violated for the practice of FGM and its medicalization. We've been honored to hear from experts by sharing their own personal experience, as the one we've heard from Ida, and experts sharing their expertise to elaborate on the health complications that was supported by a large body of evidence globally, and resources to support health workers and other stakeholders to address FGM and its medicalization. And we've also, I personally enjoyed listening to the insightful reflections and learnings and the strong commitment from the Gambia and Egypt. I think this webinar is a call to action to implement the global strategy that was developed by member states and health professionals to stop FGM medicalization, the need to involve and empower health workers as change agents through providing them the resources and tools, and the commitment by the member states through their different line ministries that include the ministries of health, gender, social, education, religious affairs, education, to have policies, interventions, regulations, and to finance interventions that empower women and girls, including survivors, on the health-related consequences and challenge the beliefs and values that drive this practice so that they become change agents themselves. We thank you for your participation and ask you all to take action now and join to end FGM and its medicalization. Thank you for being with us and wishing you a pleasant morning, afternoon, and evening.
Thank you. Thank you. Bye-bye.
Thank you, Sal.
Thank you.